Okay. Does anyone have any questions for Jim or any of the speakers? Oh, yes, Girish, you can definitely ask one.
Excellent presentation, Jim. I just had one query. What makes an oligodendroglioma anaplastic?
Yeah, I think that's a good question. And, at this stage, I know that's still made on a morphological diagnosis. So, the molecularly, I think a grade 2 and a grade 3 oligodendroglioma look very similar. It's really just whether there's the presence of microvascular proliferation or necrosis or mitoses. But biologically, what's the difference between a grade 2 and a grade 3? There's not a lot that distinguishes them. And, although CDKN2A loss is relevant for the astrocytomas, it hasn't been included as a relevant biomarker for oligodendroglioma. So I think that's probably an ongoing area of research, which, will help us determine perhaps some of the grade 2s that might do worse as well.
Matt, you've got your hand up.
I've got two questions. The first one for Jim and the second one's for you, Prof. Drummond. Jim, just with the vorasidenib, it seems to have very impressive divergence in those survival curves. Do you think there's enough evidence that this is something we should be using clinically, or is there a chance that, overall survival won't be as impressive with sort of more long-term data?
I think that's the thing that we're struggling with at the moment. So I'm definitely in the camp of a believer that this is real. The hazard ratios, when you look at them for the progression-free survival and time to next treatment intervention, are very impressive. They're sort of in the order of 0.3. And because there was crossover, so they unblinded now and there's crossover, I don't think we're ever going to read out overall survival, and because we know it's going to take a really long period of time. So we're going to have to make decisions based on this. The other thing to remember is that it's a very select group of population. So all of these were patients who didn't, have surgery was more than 12 months ago. They were good performance status. So these are sort of our best of the best low grades, essentially, who have been included in this trial. And we're going to need to know, sort of have larger studies to be able to sort of more broadly generalize it into the future. But, I think we're working with the company to make this, go through PBAC and TGA in Australia and elsewhere. I think, yeah, absolutely.
I'm going to let your one last question, Matt.
Last question's for you, Prof. Drummond. You mentioned in your talk that awake craniotomy is a very easy technique. I don't actually agree with you there. You've done fellowship level training and would have one of the largest experiences in Australia with the technique. And what I've sort of observed is that people without those two things, which probably most people don't have, the typical pattern is that surgeons will lose confidence and under resect, or even potentially not select the cases appropriately, or very occasionally cause a complication. I just want to ask you what your proposed criteria is for what training and accreditation you should have to perform an awake craniotomy.
Well, firstly, you should have one or two people in a unit who learns to do this very well. It's not something that should be done by everyone. I think, yes, you need some sort of fellowship training, whether that be, a year-long fellowship somewhere, or whether you spend 3 months intensively with someone who does a lot. But then it's like everything. It's like your learning curve with temporal lobectomy. Unfortunately, there will be a learning curve. My key point is make it common. So if you're going to do awake craniotomy, do it a lot, learn, read, get better as you go along. And then I think it's much more simple than a lot of other surgical procedures. But I'll take it that at the beginning, it seems more difficult. But the point is to get some background, make it a common procedure, and then learn as you go. There's nothing really that's easy at the outset, is it? Okay, any questions not from faculty? Before we got one. I've got a question from not faculty. This is good because everyone's waiting for morning tea, but this is good.
Thank you, Dr. Roman. Dr. Kang from Children's Hospital number 2, Ho Chi Minh City. I have a question for Dr. Guzman about the temporal lobectomy. So you say about you remove on the especially in the superior temporal gyrus. But in facial case, the superior temporal gyrus is not related to the pathology, especially in the children. Sometimes the carcinoma or the pathology is only in the hippocampus. So should we preserve the superior temporal gyrus? The second question is the posterior borderline of the hippocampus for disconnections. What is maximize to disconnect of the hippocampus? Thank you.
Did you get that through, Matt? So the first is about should we be preserving the superior temporal gyrus, and the second is about the posterior margin of the hippocampal resection.
Okay. Yeah, I mean, the boundaries of the neocortical resection and the STG are controversial. And very, I've worked in many centers and spoken to many surgeons around the world, and there's a lot of variation. Some centers preserve the STG in the dominant hemisphere. In Canada, I think they opt to even map it out awake. There are some centers that preserve the STG in all cases. We've actually found the opposite. We haven't had major language implications from taking the STG, and I take the same amount of STG in both the dominant and non-dominant hemispheres. I think part of that question was asking whether you actually need to take the STG if you've got a mesial cavernoma or pathology. And the answer is in some cases you will, and some cases you won't. Our experience is you can work out in which cases the lateral neocortex is involved with stereo EEG. Sometimes there are other biomarkers like PET, SPECT, and other things, which will lead us to do a selective amygdala hippocampectomy and not take any of the neocortex. But I would just caution you that even if you have a cavernoma in the amygdala or the mesial temporal structures, first of all, you may be dealing with an FCD type 3, where you have a focal cortical dysplasia adjacent to a pathology. And second of all, you need to look really carefully because often you'll have a sclerotic hippocampus or some other type of pathology. And certainly when you look at the selective data compared to the open data, whilst this is a little bit controversial, the meta-analysis that have covered this topic have pretty much always shown that the neuropsychological outcomes are pretty similar between the two techniques, but the open ATL with STG resection actually improves the rate of seizure freedom. To answer that, though, I do think stereo EEG will have a role in sort of refining and tailoring the operation. The last question part, I didn't really catch that well, but from what Professor Drummond sort of suggested, it's about the extent of the hippocampal resection. There's a landmark study.
The posterior margin, Matt. How do you define the posterior margin in the shortest possible time? Because we all want morning tea now.
Yeah, well, I much prefer to talk about extent of hippocampal resection than eat morning tea. So I'm going to carry on a little bit. But there's a randomized controlled trial that was done from many years ago that looked at taking the posterior extent of the hippocampal resection to the peduncle versus to sort of the line of the aqueduct or tectal plate. And it showed superiority in seizure freedom outcomes by taking your hippocampal tail resection to the level of the aqueduct or superior colliculus. Just be careful, it's not technically the tail of the hippocampus, it's actually the posterior mid-body. But there's a lot of criticisms of that trial. Like one of them is that none of the patients had post-operative MRIs. And if you actually look at where the line is of the front of the peduncle, it almost is just sort of in line with the sort of start of the hippocampal head. So it's essentially a study looking at amygdalectomy versus amygdalectomy plus hippocampectomy. So given all that, we still routinely take our hippocampal resection back to the level of the aqueduct, and we use the stereotactic navigation to confirm that. But there is more modern evidence, and there's a really nice paper out of the UCL group on this that shows that perhaps taking the hippocampal resection that aggressively posteriorly actually doesn't improve seizure outcomes and actually worsens memory outcomes. So I think there will be increased study on that topic that come out in the next few years that will hopefully definitively answer that question. I hope I've addressed your questions well.
Thanks, Matt. Okay, I think we've gone over time. Thank you, to our online speakers who've come in to add some variety to our program. We really, really appreciate your input. So thank you very much. Let's give them a round of applause. And we will see you all back here at 11 o'clock. Thank you. Thanks, guys.
Thank you.